platform or lecture. And so DAISER actually means platformer. There is a little bit of logic in there. I've been really fortunate to have 3 stages to my career. The early stages of my career were working in metabolic medicine, mainly obesity, diabetes, and rare genetic disorders. I then transitioned and retrained in technology in West Coast in the US, retrained in AI, East Coast US, and then I started building large technology platforms. I'm very privileged to have built the UK Intelligence Centre for the Department of Health, using large language models before they became sexy, and machine learning, natural language processing. And that now identifies any new medicine coming to market. I've also worked in this strange role between academia and industry. So I've built companies, I've started them, I've been a founder. I've also worked with some of the world's largest companies and regulators. Today, I still span that world. I'm an honorary professor, but I also help chair the AI in healthcare programs for the Medical Research Council and the EPSRC in the UK. And I think it's really important to bring together scientists, businesses and regulators all together. And that will probably come through in my talk today. Today, I'm going to talk about just 3 things. And the first is the movement of care from the clinic to the community. I'm also going to provide a pragmatic narrative of what I see happening in the marketplace. So by the marketplace, I mean the companies, the innovators that are out there delivering. And I'll be trying to use some frameworks and the product process framework to understand that. But all of this is to try and persuade you that now is the right time to talk about personalized care, and the transition that we're seeing across the markets mean now more than ever, we should be thinking very clearly about how we provide more personalized and more precision care to people. And I'm going to talk about that at the end. So by the end of this talk, I hope that you can understand where precision and personalized care fits into not just the technology of today, but the care process and the policies that we see today. The most profound thing that we see across nearly all developed nations, a change in the policy of the access of care from the front door, the bricks and mortar of doctors and nurses and allied health professionals, to a digitization, ultimately making the front door for health and care being your mobile phone. Now, for me, that's the most pivotal change in healthcare that we've seen in nearly 100 years. And what it's doing is it's following the same pattern we've seen in other sectors. So in banking, in commerce, and in socialization, we've seen those transition from the high street into the palm of your hand. And what we're seeing is a very clear view from government, from regulators, that the same needs to happen for healthcare. Now, the reason this is really exciting to me is because we can start to think about how we plan for this accordingly. And as Jan said at the very start, translating innovations into care is very important to me. And so what we typically see in healthcare are a number of failures. I'm going to put these at the front to try and encourage you to be thinking about these from the very start of your innovation. Now, classically in technology, we think of scale, and there's a really beautiful piece by Clayton Christensen that talks about crossing the chasm of where you go for early innovation, you cross the chasm into mass adoption. Whilst that's a fantastic model, it's not quite right for healthcare. So what we see is not one chasm, but we see 3. The first one is great idea to minimally viable product. And what that needs is it needs knowledge, it needs funding, it needs technology, and it needs design. Once you cross that chasm and you've got something which looks amazing and everybody gets excited about, you then need to go from minimally viable product to clinically validated. Importantly, that's a different type of knowledge, a different level of funding, different approach for technology, and again, a different way to design for accessibility and design for efficacy. And only at that point do you start to get scale. And this is really important because what we see are lots and lots of great ideas, but we see very few of these used at scale. And the reason for this can be seen in a clear model. So this is a model called the product process innovation model. And what it says is that when you get a new technology trigger or a new idea, you'll see an increase in the rate of innovation over a short period of time, at which point that begins to plateau off. And there's a focus then on process innovation. And process innovation is what it says, it's making the processes more efficient. And this is really a really interesting model to overlay across innovation. Now, for those of you that know me, I love bikes, and bicycles are probably the classical model for product process innovation. So bicycles used to look different. Now, if we have a look today, they're all the same. 2 triangles and a set of forks. That describes nearly every type of bicycle. But what we've seen is bicycles becoming more efficient. We saw mountain bikes where you could get suspension. You could have different variations where they became lighter and they became stronger. And dare I even say it, we now even have electrical bicycles that allow people to access cycling across all ages. But this product process innovation model happens again and again. Cars used to look very, very different. It's mind-boggling that Henry Ford brought the process innovation of how you build them on a factory line. But to the point where today, building some of the fundamental building blocks of cars like the chassis is so complicated and expensive that there's probably only 2 handfuls of chassis across all of the models of car across the world. Probably my favorite example of product process innovation is McDonald's. Beef burgers, they all look the same. What McDonald's did is they really majored on the process and they allowed beef burgers to scale across the globe. Now, what you can see if you begin to look through that product process innovation model, you can see what's happening in health and care today. So in healthcare today, you can see this proliferation of innovation. And I've been really lucky to work with innovators across a wide range of sectors. So from Parkinson's disease, obesity, asthma, heart disease, lung disease, diabetes, sleep, pregnancy, smoking cessation, skin condition, heart disease, mood, nutrition, exercise. And they were just the services that I built. What you actually see if you helicopter right back is globally this thriving innovation ecosystem where there's 250,000 digital health apps out there. The problem is that less than 10% of these have more than 10,000 users. And of those, even fewer are effective. So when we look at that chasm, the 3 chasms, digital innovation is dropping, and I think it's the elephant in the room. There's lots of innovation. There's very little that's used every day in care. So what we see is this crossover point where it's what we call a dominant design. So digital health services are more similar than they are different. So dementia, diabetes, and cancer are nearly exactly the same in the functionality and the user journeys. The way they're used is very different, of course. But from a design perspective, they're very similar. You have the same functionality on the bottom. You have the same types of data flow. And that's important because what it shows you is you can then begin to track what's happening across the world. So in this, you can see what I call 1st generation digital health services and 2nd generation digital health services. And these are moving, by the way, so some of these might be in the wrong place, but 1st generation were the first companies to come into this space. And I know because I've built some of these 1st generation companies. What they do is they provide care for a specific condition, obesity, diabetes, Parkinson's disease. And then over time, they've begun to focus on the process. So either using chatbots or using early types of machine learning, not AI, it's more business principles or processing to try and make the system more efficient. The next generation that we're seeing are very, very different. These are not carrying the technical debt of the 1st and 2nd generation of companies, and they're beginning to focus on platforms rather than point solutions. So instead of building out a service for weight management, diabetes, Parkinson's disease, or sleep, these are platforms that are doing multiple things together. And this is the dynamic that we're seeing, which is the first and second generation companies were building services for the end patient. They were building it for a specific point in care. Whilst they're very effective, what they don't do is they don't solve the real problem, which is the recognition that for most of healthcare, it's a business to patient organizations. What they've done is created a really effective tool for a single patient to use, but they weren't thinking about the healthcare system. So how does a healthcare system buy 20, 30 different services, 20 or 30 procurement routes, information governance, information security, and then multiple onboarding routes? The reality is it's too much. So systems don't buy digital health services at scale today. So the transition to platform was a natural evolution to recognizing that the buyers, the people who pay for this, want platforms that can do multiple things. Now, the exciting thing there for me is it begins to open the door to more precision and more personalized approaches, because you start to close the loop of feedback. And what we see now is the focus on process innovation. So once you've put in place platforms, you can then start to think more clearly about care. And personalized care, when you think about it across their whole care journey, it starts to bring together prevention and treatment. So for me, they're no different. They're just part of the same continuum. And what we're doing is we're collecting information, whether it's a diagnostic, so do you have a disease or not, or a prognostic, or will you have a condition, or are you at risk of it? At which point you're beginning to guide people of two different directions, either prevention or treatment. Healthcare systems across the world are very good at the treatment side. And what they're really focusing on is treatment efficacy and side effects. And we have all of our regulatory frameworks and all of our service provision built around those things. So if we look at the way that medicines are taken to market, it's around a single dose. It's around making sure it's safe and that it's effective. In contrast, prevention services are much earlier, less mature in the infrastructure to deliver them, the reimbursement pathways. And whether it's medicines for prevention, risk avoidance, so either not taking alcohol or other things that are not good for you, or lifestyle changes, we're very poor at implementing those at scale. And this isn't at an N of one level. This could even be at a national population level. So can we put in place the policies and procedures needed to prevent disease? But with the advent of platforms, we can start to look at healthcare in a very different way. Instead of focusing on an individual presenting to a doctor, we can begin to explore population health. And population health is taking an entire group of people, a nation or a community of people, and then beginning to understand the subgroups within it. And when you begin to understand the subgroups, it could be around a disease, it could be around a geography, or it could be about a risk. What you're trying to do is identify these subgroups, at which point you can begin to explore how you provide more personalized and precision care. Now, I'm just going to take a moment to differentiate between those two terms because it's really important. So precision medicine is where this whole field really started. And it started off with differences in clinical diagnostics. And it was looking at genetic phenotyping. Is the classical model of monogenic diabetes is the one that we use all the time. In contrast, personalized medicine is more the behavioral side. It's where you live, it's what you do. And what we're seeing is precision medicine and personalized care coming together. So how do you get better at diagnosing and understanding individual variants in a disease, as understanding what somebody can and can't do, but can they afford to eat better? Do they have time to do exercise? Do they like exercise? Do they respond to it? So this world of precision medicine and personalized care is being unlocked. But my caution is that as we're diving deeper into the data, We're beginning to understand the subtleties of individual variation beyond genetics and the environment, or even just your age. To understand there are modifiers that go through this. So your gut microbiome, your skin microbiome, your epigenome, these all change with your environment and your genetics. Health conditions are linked, so diabetes changes heart disease, changes cancer, and the way that people behave influences the trajectories of disease. So individual variation is just not one single trait, it's actually a whole number of things put together. And that creates a challenge for us as we begin to explore individual variations of making sure that we have representative samples of the right cohorts, the right populations, and the data scientists need to be super clear on what they are and they're not measuring. Because if we begin to build out this next layer of personalized care and precision medicine based on AI, the data we train it on is absolutely important. And my worry at the moment is that we don't have the right data sets and we're reinforcing many of the data biases that have existed in healthcare for many decades. And what we're doing is widening inequality and inequity in healthcare. And even if we do get these things right, we also need to recognize that for personalized and precision medicine to work, we need buyers to change their behavior. We need to understand how it fits into a regulatory framework. Regulatory frameworks are typically built around medicines and services around medicines. So a single dose, is it safe? Is it effective? And they build the procurement and reimbursement models around those. As soon as you begin to acknowledge that Jan's different to me, different to Dominic, it's a completely different way of thinking, and the way that we begin to regulate and pay for these services is very different. And finally, we've got these legacy healthcare systems, real people, actual intelligence, sat there that need to roll out this next generation of services. So we need to make sure we have the training programs for healthcare providers so that they're trained in data science, artificial intelligence, and understand what things are and what they are not. But I think probably the best way to highlight this is if we look at how long it takes to bring a medicine to market, 10 to 15 years, these things are like oil tankers. You know where they are, they move very slowly, so regulators can keep an eye on them and they can move accordingly. And it'd be like little tugboats and nudge it into the right direction. In DAISER, we could build an entire care pathway in 15 hours. They're fundamentally different way of thinking, and that means you need to be really aware of the regulatory environment that you're coming into, because if you don't do it carefully, you can drop into the chasm because people are not able to keep up with you. And a great example of that is some of the deep learning and machine learning technologies we have available today, we can't use in care. The regulatory environments just stop them being used. Or they're classed as software as a medical device, which means they're so expensive, nobody can afford to buy them. So my ask here is for you to really think carefully, and as we're doing research and we're building companies, be really mindful that it's not about the next paper, it's not about the next IEEE presentation. We're doing this to improve care, and that means that we need to work together with different groups all together. And there's a nice framework if you want to look at this. So this is a framework called the NATH framework from Trish Greenhow. And I'm showing this because it gives you a way to think about this complexity all in one place. We're really good at focusing on patients, but my encouragement is to think about how do you engage healthcare professionals and co-design so that you can activate them so that they're ready to go into the system. And within the system, have you got the right policy alignment? Have you got the health economics in there? So for us to effectively implement personalized and precision care, we need to embrace all three parts of this Lego puzzle all together. So my final two slides are to say, this is what I do every day. And DAISER we built as a modular platform to allow people to effectively embrace this variation in data but do it in a safe environment that regulators could understand, and also where healthcare teams could use the latest AI and ML technologies without having to understand how you write in Python or Django, but they could begin to use these tools because they're the clinical experts. What we have is a Lego brick type platform where you can build native applications in a matter of minutes, but also you can build data ecosystems. And importantly, these are going to link in with things that are around it. Now, what I hope that will do is it will help us embrace the complexity of data that's needed to understand individual variation, but in a way that allows people to use it in a very practical sense. So in my talk, I've covered 3 different topics. The first is the focus on the transition of care from the clinic to the community, and we see that across many nations. We can't afford not to, and consumers are expecting it. The second is if we have a look at what's gone in the market and we think of it with a product process lens, we can see that the next thing that's happening is platforms. Please don't build another point solution. The world does not need another app. What it needs is a platform and multiple services that can be used at scale. And when we do that, we unlock precision and personalized care. But we need to be careful and purposeful about it. We need to bring data scientists with statisticians, with clinical care teams, bring those together to effectively deliver at scale. So at that point, I'd like to thank you for your attention, and I'd be pleased to answer any questions.